I have attended a few talks of ma'am, and she makes it very interesting with putting a lot of cases, a lot of surgeries, etc., etc. Welcome, ma'am.
Thank you, sir. Thank you for your wonderful introduction. Yeah, it's always a pleasure to be with Dr. Kiran, sir. Sir, able to hear me, sir?
Yeah, absolutely, ma'am.
Yeah, yeah.
Yes,
Dr.
I will introduce Sudhir sir also, ma'am, if it's okay.
Yes, sir.
Yes,
yeah,
yes.
I think sir is online, sir. I could not see him.
Yes, he's there, ma'am.
Okay, sir. Okay, sir.
Okay, ma'am. So I would like to introduce Dr. Sudhir sir. Currently, sir is the consultant gastroenterologist, hepatologist, and therapeutic endoscopy specialist in the prestigious KIMS Hospital, Hyderabad. I would say sir actually has got a lot of academic interests and qualifications. I'll just name a few. Sir actually has a fellowship in advanced therapeutic endoscopy from the Dinanath Mangeshwar Hospital in Pune. Sir was the consultant gastroenterologist between the year 2016 to 2018 in the prestigious NHS Trust Hospital, Coventry in Warwickshire in UK. So sir has spent quite a lot of time in UK. Sir was the national trainer in SPR UK and has done quite a lot of training in gastroenterology, hepatology, advanced clinical fellowship in endoscopy, gastroenterology, internal medicine. So quite a lot of rotations in various hospitals in various important places in UK. Sir has also got a lot of publications. So just to name a few, Sir has done a publication on cecal ulcers, not a Crohn's disease in 2017, needle aspiration technique for diagnosis and management of mucosal pneumonitis in gastroenterology today. So Sir has got quite a few public. Sir has also delivered talks in various forums. Sir has also won quite a lot of awards and honors like distinction gold medal in ophthalmology in 2001, the statewide medical common entrance test. Sir got a 14th place, so that's very nostalgic. Sir won also the Sivananda Endowment Medal in ophthalmology. So with this short introduction, I would like to hand over the podium to Pujita ma'am and sir. Welcome, ma'am.
Yeah, very good evening to all the doctors. So here Dr. Pujita and Dr. Sudhir sir were there to discuss regarding liver diseases and pregnancies. Sir, able to hear me, sir?
Yes, ma'am, definitely, ma'am.
And can the screen is visible, sir?
Yes, ma'am. Ma'am, you could probably go to a slideshow.
Okay. So, is this fine, sir?
Yeah, absolutely, ma'am.
Okay. So, evaluation of the pregnant woman with abnormal liver enzymes. So, this is like when we discuss like whether pregnant patient is presenting with abnormal liver test, they should definitely undergo a standard workup as a non-pregnant individual. So any abnormal liver test in pregnancies should be treated very seriously, should be taken into consideration as very seriously, and we should go into the further evaluation. And when it comes to the incidence of abnormal liver test in pregnancy, it is around 3 to 5%. And it's a challenge. It's always a teamwork. It's always a challenge for the obstetrician, intensivist, and the hepatologist also. So first, I think let us discuss the normal discussion about the liver, physiological changes in the liver during pregnancies, and let us go to the diseases, which will explain how we are going, how liver diseases are how portrays in the pregnancies. And we also will discuss about the case presentations, like we have taken up an interesting case presentations like 3 to 4, which we have dealt successfully in our hospital. And of course, with the team of Dr. Sudhir sir. So let us briefly discuss now about the physiology of the liver. And as we know that hepatic blood flow is maintained as a constant rate in the pregnancy, And see, we know there is a marked, despite of the marked changes in the cardiovascular system, because we know there is an increase in cardiac output in the pregnancies. So when the blood flow increases to the kidneys and other organs, but hepatic blood flow is usually unaltered, which results in the decline of approximately 35% in the proportion of the cardiac output delivered to the livers. When it comes to the biochemical changes in the pregnancy, total serum protein concentrations will be decreased by 20% by mid-pregnancy. And substantially, there is a decrease in serum albumin. And we know this occurs because there will be increase in total blood volume, although some proteins remains unchanged or increased in concentration. And there is also significant raise in the serum fibrinogen levels, and other coagulation proteins like including factors 7, 8, 9, and 10 may be increased during the pregnancies. And few studies, there are no strong evidences that significant raise in the bilirubin, but there is a significant raise in the bilirubin levels, maybe because of the few changes which are already present in the non-pregnant females. So as we know, there is an increase in alkaline phosphatase activities in the third trimester. This is because of leakage from the placental alkaline phosphatase from the maternal circulation, from the maternal bone turnover, because of increased maternal bone turnover. And there is an serum bile acid levels is also has to be measured in the pregnancy, because it is very important to diagnose the cholestasis. And these levels will be usually normal in pregnancy. They usually be unaltered. And levels of ASTs and ALPs are also usually normal, but alkaline phosphatase is always increased. So as a summary of physiological changes in the liver during pregnancy, there is an increased blood volume and cardiac output, which raises around 35 to 50%. Alkaline phosphatase levels are increased, that might be 3 or 4-folded. And the clotting factors changes, which creates a hypercoagulability state, which is very important for us to monitor. And there will be a decreased gallbladder contractibility, and hemoglobin might be decreased because of hemodilution. Uric acid levels will be decreased. Albumin, total proteins, and antithrombin 3 concentrations are decreased because of hemodilutions. And actually, we won't see any changes in the aminotransferase levels, bilirubin, and prothrombin times. So we have to take a complete history. Physical examination has to be done properly, and a standard serological test has to be done along with this clinical history as well as the physical examinations. And after maybe completing all these things, we may divide the patients into a different criteria, that is like whether the pregnancy is whether the liver disorders are pre-existing or coincidental, which are not related to pregnancy, or which are related to pregnancy. So when we go to, this is a kind of classification how we can trace out the liver diseases. So this is like pre-existing liver diseases. Usually it will be portal hypertension, cirrhosis or autoimmune hepatitis, Wilson's disease, or chronic infections like B, hepatitis B, C. And it's a coincidental but not related to pregnancies are acute viral hepatitis, alcohol-related diseases, gallstone diseases, alcohol liver diseases. Liver diseases which are more induced by the pregnancies, we can divide them as in first trimester, second and third. Usually in the first trimester, we see the hyperemesis gravidarum. Second and third, we usually see intrahepatic cholestasis of pregnancy, preeclampsia, eclampsia, HELLP syndrome, and acute fatty liver of pregnancy. So when it comes to liver diseases, as we discussed, we can divide this into the 5 criteria. And so let us discuss briefly about the things which were more important in pregnancies. So, and sir will be discussing about the external, which are exterior to the pregnancy. So in the first trimester, we usually see the hyperemesis gravidarum. So in the first trimester, liver changes we usually see in the hyperemesis gravidarum. In the liver test, abnormalities are more common in this. 50 to 60% of hospitalized women will have the elevations in the aminotransferase levels up to 200. Although AST and ALT are always 20 times the upper limit of normally, rarely, which has been reported, but it's not mandatorily. We have seen all the cases of hyperemesis. We usually we have to see this kind of levels. It's not mandatory. It can be depends upon the severity of the disease. So sometimes we have seen the severe cases of hyperemesis aerogratum. We have even seen the serum amylase and lipase values have been elevated, and jaundice and hepatic synthetic dysfunctions are very uncommon. Although women with hyperemesis gravidum has increased rates of low birth weight, and this is all we usually know. This may occur because of decrease in the nutrition because of hyperemesis, and small for gestational babies. Preterm deliveries do occur if there are any dearrangements in the liver functions, and we have even seen the poor APGAR scores. But the final outcome will not be very dangerous; it will be favorable. So management is always supportive. That is like hospitalizations for IV fluid replacement, correction of correction of the electrolyte abnormalities, and use of antiemetics. So we are not much going into the individual treatments for the each and every disorders. We are trying to constrain to the liver problems, and maybe in the case discussions we'll come to know how we are going to treat in each and every case. So when we go to second and third trimesters, the most common which we usually see is intrahepatic cholestasis of pregnancy. So cholestasis of pregnancy is most common liver disease in pregnancy, and it ranges in between 0.3 to 5.6%. It is usually present in second and third, but usually the patient's complaints of pruritus involving the palms and soles, which as well as the rest of the body also, with elevated bile acid levels, which usually resolves after the delivery. And jaundice also can occur in less than 25% of patients. And if the jaundice is presenting symptom, further evaluation for alternate explanations is necessary. And as we know, intrahepatic cholestasis, there will be a fat malabsorption, can result in the fat-soluble vitamin deficiencies requiring supplements. So what are the risk factors? So usually intrahepatic cholestasis is more common in the maternal age greater than 35, and history of any usage of oral contraceptives, personal or any family history. Family history, if it is strong family history, always increased risk of cholestasis. And some studies have been shown they are usually interrelated with hepatitis C, cholelithiasis, and non-alcoholic fatty liver diseases. And they are more common in fertility treatments, with the history of fertility treatments also. And evaluation of alternate etiology has to be done. So when it comes to the investigations, the most important investigation which rule out the intrahepatic cholestasis is bile acid concentrations. If they are more than 40, definitely they are into high risk, and we have to further evaluate it, because as we know, this bile acid levels are very dangerous in the sense they may correlate with the fetal distress. Sometimes we may see IUDs in the third trimester because of elevated bile acid levels, and aminotransferase levels may also be elevated, and ultrasound should be performed to exclude the cholelithiasis. So maternal outcomes are not very dangerous in this intrahepatic cholestasis. The outcomes are really good, but fetal outcomes we have to take care of fetal outcomes, because we usually see fetal distress, meconium stain lichens, preterm deliveries, prematurities, and intrauterine IUDs. And when it comes to first line therapy for intrahepatic cholestasis, ursodeoxycholic acid. Usually we give 10 to 15 mg per kg of body weight. It is safe in the third trimester, and no adverse maternal and fetus effects will be seen usually. And this has to be given, this therapy usually normalizes the serum bile acid levels, and we have to be and we usually see minimal accumulations in the amniotic fluid and cord blood. So women who are treated with this kind of with this treatments, they usually have less pruritus, their liver functions will be arranged, and the fetal outcomes are also usually it will be really good. And this is more effective than the dexamethasone and other alternative treatments. Dexamethasone is needed because we usually preterm deliveries are more common in these complications. So we usually concentrate on fetal lung maturity rather than the liver functions. So any liver enzymes dearrangement with bile acids which were increased, we need to think about the early deliveries. So as an obstetrician, our target of delivering a baby will be around 37 weeks. Once if it is reached, we should not wait further, or we should not continue the treatment for bile acid treatment has to be continued, or we should not target about decrease in the bile acids. As we deliver the babies, usually 50 to 60%, all the levels will be neutralized once the delivery happens. So maybe we need to target for 37 weeks, and once the 37 weeks are reached, we need to deliver the babies. And as we know, postpartum, we usually have to check about LFTs and bile acids after six weeks. So the most important, which we usually consider, which we commonly seen, is preeclampsia and eclampsia. So when it comes to the definitions, we know that hypertension more after 20 weeks with 140/90 systolic and diastolic, with proteinuria more than 300, and organ dysfunctions as renal impairment and liver involvements, neurological and hematological complications and retroplacental dysfunctions, and maybe very severe preeclampsias. We usually see the hepatomegaly and hepatocellular injuries. 7.5% of all the pregnancies are usually affected, maybe of all the pregnancies are usually affected with preeclampsias, but very severe will be very rare. We usually see only 25 of preeclampsias. So as we know that eclampsia is characterized by presence of seizures. So liver involvement is a not common expression, but when it does occur, symptoms are generally non-specific. But hepatic involvement, usually the patient's complaints of epigastric and right upper quadrant pain. We know that because of stretching of the Glinsen's capsule. And what is the pathology? Why this liver is getting infected? Why the liver is getting affected in the PIH is like, this is mainly because of fibrin depositions within the hepatic sinusites. They causes a sinusoidal obstruction, which leads to vasospasm in the liver vascular bed and liver ischemic. Ischemic changes do occur. And this leads to large hematomas or capsular tears, which causes intraperitoneal hemorrhages also. And when we observe that AST and ALT levels are always raised, and the complications we know about that because of the hepatic rupture of the capsule, that is like Glinsen's capsule, we usually see the hematomas. And the magnitude of liver chemistry abnormalities usually parallels with the maternal outcomes rather than the fetal outcomes. So liver test cannot exclusively be a clinical decision for the presence of normal liver enzymes, but expectant approach is usually advised until after 34 weeks of gestation. So as obstetricians, we usually see first target is like 34 weeks. And again, we usually postpone till 36 to 37 weeks. If the liver enzymes are not affected, if the platelets were not decreased, if proteinurias were not progressing, then we usually won't think about the delivery till 36 to 37 weeks. If the 36 and 37 weeks are successfully reached without any dearrangements of this blood levels, definitely we can deliver, and we can safely deliver the baby at around 36 to 37 weeks. So I request Dr. Sudhir sir to please carry on with the next presentations. We'll be very happy to hear from you, sir.
Thank you, madam. That was a wonderful introduction. I'll just start to share my screen from here.
Yes, sir.
Can you see the presentation now?
Yes, sir.
Okay, thank you, madam. So HELLP syndrome is essentially hemolysis, elevated liver enzymes, and low platelets. As the name suggests, it occurs in a minority of pregnancies, but can complicate up to 20% of cases of severe preeclampsia and eclampsia. Now, as you can see, this is actually a pattern of a spectrum of hypertensive-related liver disorders, where preeclampsia, eclampsia, and HELLP syndrome can variably occur and present in any individual patient. Usually, it occurs in the second and third trimester, but it's important to also understand that 30% can actually happen in the first week postpartum. Now, there are several risk factors. Most of you probably already are aware of this, which is maternal age, nulliparous women, and multiparity. Now, they share clinical presentations which are similar, which is why we call these as hypertension-related liver diseases. Now, in terms of HELLP, it's typical laboratory results that help us make the diagnosis. There are no specific pathognomic clinical signs Although most patients can complain of right upper quadrant pain, epigastric pain, some also have nausea and malaise. Now, it's important to identify this condition because in up to a few patients where the platelet counts fall and the thrombocytopenia is prominent and the signs of hemolytic anemia is very profound with elevations of AST and ALT and bilirubin, it can cause very serious maternal and fetal consequences. Maternal consequences can be in the form of mortality up to 3%, and progression can sometimes be rapid. But it's also reassuring to know that once you identify the condition and deliver the baby, most of these laboratory values come back to normal within 48 hours. Prognosis to the fetus or the newborn is mainly dependent upon the time you have taken to deliver the baby. Although IUGR, preterm deliveries, neonatal deaths, abruptio placenta are also reported with the same. Now, the hepatic consequences specifically are due to the similar mechanisms that Dr. Pujita has alluded earlier, includes hepatic infarction, hematomas, intraparenchymal hemorrhage. If you see an ALT that is going in thousands, then you should certainly consider hepatic infarction as the differential diagnosis. They can present with fever because of the necrosis in the liver. Sometimes shock and abdominal swelling may represent hepatic rupture. That is a surgical emergency. You have to go in with your either interventional radiology colleague or with your surgeon to correct this. Conventionally, we usually use ultrasound, and this is one place where I would recommend doing a CT if you have a strong suspicion, especially if you've delivered the baby and you're worried about it. Go for cross-sectional imaging. Now, as almost if the patient is having a contained hematoma, supportive management is enough. Now, surgery is only indicated when you are enlarging hematomas and there is evidence of hemodynamic instability. Otherwise, you may embolize them with radiologically. In rare cases, you may also have to transplant them, especially those who have not responded to conservative and standard intervention, including the delivery of the baby. Therapy, as you all know, delivery is definitive treatment, and it's important to stabilize the mom before you deliver. Steroids are used mainly for improving fetal lung maturity, although there is some evidence that it improves the platelet count, LDH, and the ALT levels. Now, especially in pregnancy who present with less than 34 weeks, you want to accelerate the lung maturity in these patients. Now, what we traditionally use is what we call as the Mississippi protocol. That includes the combination of 3 drugs, corticosteroids, magnesium sulfate, and very strict and prompt control of the systolic blood pressure. And that it is known to change the prognosis in these patients. Those pregnant women who present with this condition and have platelet count less than 40,000, you may in fact need to give them platelet transfusion before you anticipate invasive treatments. And the next, and perhaps an interesting area, which is rarer than the rest of the conditions we have talked about, is the fatty liver, acute fatty liver of pregnancy. The risk factors, usually twin pregnancies, low body mass index as opposed to the NASH, which is common in obese women, and preeclampsia is also a pre-existing risk factor. The reason why it's important is because this can be life-threatening, especially because it presents late, tends to be closer to the 3rd trimester of pregnancy, and early recognition on prompt delivery can actually save the lives in these patients for 2 reasons. One, these patients can progress to hepatic dysfunction and go into liver failure. And in these patients, it's identified to deliver the baby and support the management in this. Otherwise, the risk is both to mom and the baby. And the postpartum clinical outcome is always dependent upon the duration of the time when they are presented to the time when we have terminated the pregnancy, whether it's in the form of delivery or otherwise. Presenting symptoms, again, very non-specific. Some people have preeclampsia. One of the striking features that we see is raised ALT and raised bilirubin. If the patient has jaundice and if they develop encephalopathy, within 7 days of onset of jaundice, then it's hyperacute liver failure. And that is what we want to avoid here. Some patients do develop renal impairment, and pancreatitis is also noted in this group of patients. Now, this is a criteria that has been validated very well in Swansea in England. And if you have 6 or more of these features, then you can even avoid liver biopsy and fairly confidently make a diagnosis of acute fatty liver of pregnancy. You have to understand that the encephalopathy that you're seeing here as well as ammonia correlate very well with those levels. So even a mild elevation of AST can be diagnostic of acute fatty liver pregnancy in the right clinical context, especially if they are encephalopathic. Now, the pathogenesis is interesting. It is known that some homozygous deficient offspring lead to a problem with the metabolization of the fatty acids, and there is a spillover of these from the placenta and the baby circulation into the maternal circulation, which causes the deposition of these fatty acids in greater quantity in the maternal liver and leading to hepatotoxicity. So for the newborn itself, you have to closely observe them for so that they don't become hypoglycemic. Very rarely, heart muscle and skeletal muscle abnormalities have been reported, but for the vast majority, the prognosis is good if delivered on time. Now, this is an area where we have to understand, as Dr. Pujita first initially mentioned, any liver disease, any patient who is pregnant who presents with an abnormal liver function, you have to rule out the common things. Common things are common. So HIV, which is hepatitis A virus, happens because of fecal-oral transmission. Acute HIV has been associated with preterm labor, but largely it's safe. There is both to the mom and the baby. The pregnant state actually does not alter the course of hepatitis A virus. Most people tend to present with gastroenteritis. They may have elevation of ALT and AST and jaundice. And that is why it's important to have the hepatitis A virus IgM testing in those patients who present like this. It's important to understand, especially in the last 2 weeks of the delivery, if the mom presents with HIV, then there is a risk of having excessive outbreaks in the neonatal units because of the risk of transmission from the mom to the baby. And there is some evidence that giving hepatitis A virus immunoglobulin to the baby can help, but largely the treatment is supportive. You don't have to do anything else. Now, E virus has achieved its notoriety because of the risk associated with acute liver failure, especially in Southeast Asian population. Again, pregnant women with hepatitis, the only way to do it is to do a HEV IgM. Treatment is largely supportive, and those patients who are progressing to acute liver failure, we may need to think about transplant. And that is why it's important to keep this at the back of your mind. Now, this is not so common in India, but relatively common in the Western world is the herpes simplex virus. Although this is very rare, but presence of HSV can be a very severe presentation, and it tends to be an anictoric type of hepatitis. So you'll see the ALT and AST going into thousands, but tends not to be jaundice. The pathognomic mucocutaneous lesions that you normally see in other HSV patients are present in less than 50% of the cases. So acute hepatitis may just be the only presentation. Why is it important? Because of the high mortality, maternal mortality that can be seen in these patients. Because of such high maternal mortality, we tend to send off a sample for HSV IgM and HSV PCR. But it's important to understand that HSV IgM, the sensitivity is very limited. So PCR is the diagnostic test here. So CDC has recommended, and FDA has approved this, that you can actually use acyclovir empirically if you're suspecting HSV. Now, you also have to understand that acyclovir does have some renal toxicity. So they have to be well hydrated when you give acyclovir until such time that you get back the PCR. If the PCR is negative, you can always stop it. Now, hepatitis B virus, as any other acute infections, you can have Hep B, but it's very difficult to identify, especially if you have a chronic Hep B that has got an acute reactivation or a new acute infection. Now, by use of the HBsAg and IgM core testing, to some extent, you may be able to differentiate between the two, but the chronic Hep B is the one that causes the most problem because of the prevalence of the disease. Nearly 350 million people worldwide go through it. And there is a very high risk of mother to child transmission. Why is it important? Because the younger the age of onset at which the baby gets affected with the hepatitis B virus, the higher the chance that they become chronic HPV carriers. And the current barriers that we have is in lack of underutilization of the immunoprophylaxis and the immune globulins. So what are the risks? Say, for example, an infant has a 90% chance of chronic infection compared to 50% in toddler and 5% in adults. There are other risk factors, which is higher degree of viral count in the mom to the extent of greater than 10^7 DNA counts or more than 200,000 international units. If the mom is HBe antigen positive, the risk of transmission to the child is higher, so 10 to 40%. What is recommended? We recommend hepatitis B immunoglobulin along with hepatitis B vaccination, the first dose to be administered to the baby within 12 hours after birth. 2 additional doses need to be given. There's also an accelerated protocol which you can use at 0, 4 weeks, 6 months, and again at 12 months. Through this prophylaxis, you are able to reduce the mother to child transmission to less than 5%. The postulated causes are very high levels of maternal viremia, intrauterine infection, especially if you're doing amniocentesis, and certain mutations of HBV surface protein, which are not easy to control. The other immunoprophylaxis cause is to make sure we have to reduce this as low as extent by use of medication. So what we do is I tend to now do a viral count at the start of pregnancy when they're first diagnosed that they are pregnant. I repeat their hepatitis B virus DNA at 26 weeks. If the viral load is greater than 200,000 international units per mil or greater than 10 power 6 copies per ml, then I offer them antiviral therapy. 2 drugs that are known to have an effect, one is the commonly used one that I use is the tenofovir, and the other one is the telbuvudine. Both of them are safe in the 3rd trimester of pregnancy. You can start them at 28 weeks and continue it for up to 4 weeks post delivery. C-section is not mandated because they are HPV positive, but you only do it for obstetric reasons. It is safe to advise HPV infected women to breastfeed as it is what is important for the infant health. Now, hepatitis C virus, all pregnant women with risk factors for hep C is advised to be screened for HCV, but although we are normally routinely doing this. Invasive procedures are advised to be avoided in this group of patients because of the risk of mother to child transmission. But it's important to understand that we are now at an age where we can cure hep C. There are very good directly acting oral agents that with a 12-week course, you can achieve 96 to 98% virological clearance. And C-section again does not need to be performed routinely. Some women, if not all, can actually breastfeed patients. The only restriction, either both in chronic hep B or in hep C, are those who have cracked nipples, who are bleeding. That is the only group of women we advise to express the breast milk and feed the baby. As such, I don't advise starting hepatitis C based therapy in pregnant women because now you can always treat them post-delivery. There's only 3 to 10% risk of transmitting this virus at the time of birth. The risk is highest in those who have a co-infection with HIV, so it's important to do an entire viral screen, hep B, C, and HIV in these. The one risk factor independently known to cause increased risk of mother-to-child transmission is the PROM, prolonged rupture of membranes. But again, cesarean section does not protect itself, and vaginal delivery is safe. There are a lot of other chronic liver diseases, as Dr. Pujita mentioned, pregnant women with autoimmune hepatitis. Now, autoimmune hepatitis is a huge topic in itself. I'll briefly touch upon them. Now, anyone who has got well-controlled autoimmune hepatitis, I would actually continue them with the course of steroids. It is currently, the registry data is very clear that you can continue to use azathioprine because that is what is keeping the disease in control in them. There is some evidence that corticosteroids increases the maternal hyperglycemia, and some evidence that there may be reports of cleft palate and large babies, but that's not validated in huge, large registry data. It is safe to continue, and we only use very low dose of steroids in those who are on long-term remission in autoimmune hepatitis. With primary biliary cirrhosis, again, these are chronic conditions, very safe to give ursodeoxycholic acid, 10 to 15 milligrams per kg body weight. I would just continue it through the pregnancy. Wilson's is usually seen in young women. And this is one group of women who, although there is, because of the rarity of the disease presentation, we tend to continue the treatment with penicillamine, although the recommendation is that if possible, you reduce the dose because of the risk to the fetus. And it's most of these women who have been diagnosed with Wilson's and who have decompensated liver disease, their fertility issues are also low. So this tends to be an incidental presentation in this group of patients. Pregnant women with portal hypertension. Now, anyone who's got chronic liver disease and portal hypertension, they should undergo screening for upper GI endoscopy, it preferably before pregnancy. And if they do have grade 2 or larger varices, we electively ban them before they get pregnant. Now, some of women who are pregnant and present with decompensated liver disease, it's important, it is safe to do the varicose banding in the second trimester. Now, briefly about chronic liver disease, the fertility rate of women in this group tends to be less. So we always advise them, screen them, evaluate them thoroughly before we advise about pregnancy. Now, if women have large esophageal varices, they can be treated with beta blockers and or band ligation. I currently only use band ligation because it's very effective. And I add in beta blockers and statins in those who are higher risk of rebleeding. Now, if there is a history of liver transplantation, it is advised to continue the immune suppression, except for mycophenolic acid. Everything else you can continue. Now, specifically coming to biliary disease, cholelithiasis is very common, and it's mainly because of the increased estrogen levels, and there is cholesterol supersaturation in this group of patients. Patients can form gallstone disease newly, especially in the hyperprogesterogenic states. Traditional treatment can sometimes be used, conservative treatment in these patients, but in this group, pregnant women who are presenting with cholecystitis, I would advise them to have surgery, especially if they have choledocholithiasis with a stone within the bile duct. They need ERCP followed by surgery, because the risk of repeated symptoms in this group of patients is quite high. Although we always counsel them that if we do an ERCP in a pregnant lady, the risk of pancreatitis is high, up to 16%. We take all the precautions to prevent fatal exposure. There are cases where I've done without using any fluoroscopy, with aspiration of bile and perhaps confirming that we are in the right duct. And it is, if we are able to shield the baby, it is better to do it, and ideally prefer to wait until the second term if it's possible. But if in cases of biliary pancreatitis or symptomatic choledocholithiasis, non-intervention will cause poor outcome. So intervention is better. And as I said earlier, recurrence of symptoms is high in those who are managed conservatively. And especially if you have gallstone pancreatitis, the fetal mortality tends to be very high. So it's better to be aggressive in this group of patients. Have early surgical intervention and laparoscopic cholecystectomy, which is safe, and ERCP is preferred for treatment to clear the duct. Now, liver masses can sometimes be seen incidentally. The three common masses we see are hemangiomas. Very rare to see them presenting for the first time. They're usually incidental findings. It is very safe to give a standard vaginal delivery in these patients. Spontaneous rupture is rare. Focal nodular hyperplasia are benign nodular lesions, incidentally found at screening on ultrasounds. Again, have good prognosis. No need to do anything. The one group that needs intervention is hepatic adenomas. They can sometimes be seen for the first time. You have to do serial ultrasound scans. If they are growing more than 5 centimeters, and if you happen to identify them pre-pregnancy, I would have them removed surgically or radiologically, intervene before the commencement of pregnancy. If the size is increasing, then it's better to use second trimester or early third trimester to have surgery and have definitive treatment. Now, nothing can be stopped in this pandemic. We are in the middle of a pandemic, and to highlight to you, and I think Dr. Pujita has done some semi-research herself for our patients, because she made us pull out all the case reports that are available, 25 of them to be precise, where we've gone through it. And there is evidence of deranged liver function in pregnant patients in this who are affected with COVID. The management is still largely conservative, but because of the degree of hypoxemia, it tends to be, the mortality tends to be on the higher side. This group of patients who have multi-organ dysfunction, hypoxemia, we call them the happy hypoxers. And they tend to have deranged liver function, which can sometimes be ischemic, but it's also by the direct infiltration affection from the virus. So I will briefly stop there, and I will hand over the session to Dr. Pujita for her to go through the cases and perhaps take questions after that, if you have any burning ones. So, Madam, I think you need to unmute yourself.
Yeah. Yes, sir.
So I will stop sharing my screen.
Yes, sir.
Okay.
So thank you for a very brief and informative messages about all diseases in pregnancies and how we are going to cope up with all those things, sir. So hope we'll have a very great discussions about these 3 cases which we have dealt. And yeah, as sir told, I think in my this years of experience, we have not seen so many cases with liver function deranged cases. I mean, the number of cases what we have seen in our hospital are really more, which made us to think about or go through the studies which have shown that in COVID patients that liver enzymes were really increased. So I immediately spoke with sir because he was our COVID team in charge in our hospital. So I met sir personally and we discussed. We have gone through lots of studies and we have found that liver enzymes were deranged in COVID patients, and we have taken all precautions to protect all our patients as well as hospital. We have taken all COVID precautions, but still. After maybe in Telangana we are not having much say this kind of test or not being done in the Telangana without any other proper evidences. So we could not do COVID test for all the patients. But yes, few we have done, they came out negative, and few we have screened with chest CT, and we have screened whether they are having any opacities in the lower lobes or something, and we have taken all precautions. But as of now, we didn't get any positive for that. But we have to be careful when any patient comes with liver functions derangements. So when coming to case discussions now, first case, sir. So this we got a 34 years old female. She's a G2A1 with 1 history of abortion, 27 weeker, and she was referred from a private hospital with deranged liver functions. And her married life was only 1 year, and this was her spontaneous. She had a spontaneous abortion in the first pregnancy. That was her 2nd month. We usually take this into considerations because we always worried about any antibody rejections in the body. And the now this pregnancy, 2nd pregnancy, it was a spontaneous conception, and she had regular antenatal checkups. NTs and TIFAs were absolutely normal. The only history she's having was pruritus. The positive history where we have seen is like pruritus, and she's on tablet Udiliv for since 20 days. 300 mg BD dose.
Okay.
Sorry. Yeah. And her general condition was absolutely fair. She's not having any temperature. Vitals are absolutely normal. We could not see any icteric changes in her body. And her uterus was palpable corresponding to her age, but corresponding to her this gestational age, and fetal heart rate was also present. So she was referred here mainly because her liver enzymes were elevated along with bilirubins. So basic investigations were done and found with normal hemoglobin and platelets. There is no decrease and there is no thrombocytopenia. PT-INR was normal. Bilirubin was high, 1.9, and albumin was lower side towards lower side, 3.1, and SGOT and SGPT were almost 400 plus. APTT was mildly raised, that is 46, and in CUV we could see bilirubin 1 plus with no ketones, no proteins, and her viral screening was negative. So, as an obstetrician, sir, she was 27 weeker. I always want to think whether whether I can postpone this pregnancy or not. But after saying this liver function and liver derangements, I always feel it's better to terminate. Whether my decision was correct or not, and what you think, what would be the diagnostic, sir? I mean, diagnosis for this kind of patients.
Thank you for the summary, madam. See, you can see that the ALT and AST, which is SGOT and SGPT, are elevated. The hyperalbuminemia may be a reflection of the pregnancy itself. The hyperbilirubinemia, we know that can cause fetal distress, and that is what determines the need to intervene early in these patients.
Yes.
Now, if you look traditionally at the spectrum of the hypertensive-related pregnant conditions that we have talked about, the patient does not have any proteinuria, her blood pressure is stable. So having pruritus may tempt us to think that this may be intrahepatic
Related to
pregnancy. But the rising bilirubin and the trend of the bilirubin, if it's going up, then early intervention may be necessary in this patient.
yes.
But there is also a school of thought who would give her high dose urso at this stage and wait and see. But considering that you've already used urso for 20 days and the patient is getting worse based on what you're telling me, early intervention may be justified in this particular patient. The one school of thought that I just want, then the caveat that I want to put in here is that although cholestasis per se means that you would see a raised alkaline phosphatase, it can also cause you to have raised ALT and AST in some patients. That is why it's important to see the spectrum of the change. Now, it is evident from the blood test that you're showing that this is not HELLP or unlikely to be HELLP because there's no hemolysis, the platelet count is stable,
Yes,
and the patient is not yet in any form of liver failure. So that is where you have a small window of opportunity to counsel the patients, observe them maybe for 24, 48 hours, see which way the bilirubin is going. And if it is going up, then perhaps early intervention with delivery would be the right thing in this particular patient. That time period will also give us the ability to be able to send off a liver screen, get the hepatitis A IgM, E IgM, and check for other conditions that are commonly seen. And in the meantime, you would get your ultrasound scan. I don't think this is COVID. This is not fitting in with COVID. But in the pandemic, you have to think about it. So that's how I would approach this patient. So you give yourself a little bit of time, see how the patient progresses, and then perhaps proceed. If the bilirubin and jaundice are worsening, I would advise early intervention rather than
early intervention.
What is against this, though, is what is important to realize is that at 27 weeks, you are risking the fetus. So you have two people to think about here. One, the mom, and the second is the baby. And that's a tricky decision to come to. And that is why it's important to have that 72 hours or 48 hours to observe this patient, give your steroids to enhance fetal maturity, see how the patient is progressing. I think that's what we did on this particular patient, if I remember it right.
Exactly, sir. Perfect, sir. Yeah, we have done the same. And when we and sir was discussing about how to go ahead with this case, we have first admitted the patient, corrected her dehydration if she had a mild dehydration because we corrected with IV fluids. And first day we were not in a hurry to deliver her because hemodynamically she was absolutely stable. There is no thrombocytopenia, but only worrisome is like APTT is based towards higher side. As an obstetrician, I'll be in a hurry because I always want her not to land up with any PPH or any bleeding from the suture site. But whatever sir said is absolutely correct. Even I need 24 hours to 48 hours to give her steroids, to give her neuroprotection with magnesium sulfate. So we need to go ahead with neuroprotection and steroids. Lung maturity has to be done, and we have repeated the test within 12 hours again. If there is no much dearrangement, again after 24 hours. And I think, sir, here we also gave her liver enzymes replacement. Like, you want to put a word about that, sir? We have.
There is some evidence that in acute hepatitis, by supporting them with glutathione and acetylcysteine, the liver function improves. Now, it does help. The evidence comes mainly from acute paracetamol toxicity, but it has been extrapolated to use in other liver conditions variably. Although the final outcome may not be different, but the rapidity with which the liver function improves does change. So that is the role in giving them. But the outcome in terms of morbidity and mortality haven't been shown conclusively in many studies. But all the data that comes from is the paracetamol toxicity treatment.
So this enzymes, whatever sir has given, has helped us to maintain the functions rather than deteriorating. So it definitely helped us to postpone the pregnancy at least for 48 hours. And after coverage, we planned an elective C-section after taking a high-risk consent because APDT was being raising. And we kept an arrangement of blood as well as FFPs to have it. We didn't transfuse the patient, but we transfused FFPs on table so that not to have any intraoperative complications. We successfully delivered 1.2 kgs baby. Where there, and I'm sorry to, I forgot to tell you this, ultrasound findings were like there is a single live 1.2 kgs baby with normal placentations and normal amniotic fluid, and Dopplers were absolutely normal, which I felt it was a beautiful time for us to wait for at least 36 to 48 hours. There were no Doppler changes in this patient in the scan. So we waited, we delivered, and after delivery, as a miracle, when we repeated within 24 hours, I guess almost the parameters were decreasing. There is a decrease in trend has already followed, and her bilirubin has improved. Her SGOT, SGPT took its own time, but I can say there's a decreasing trend has started within 48 hours. APTT was immediately corrected. The next day itself, the APTT was corrected, and the patient was normally discharged on 5th post-op day with normal bilirubin levels, but not SGOT, SGPT. We have sent her home with the suggestions of Dr. Sudhir sir, and normal. We avoided like NSAIDs and all as we take precautions for coagulopathies. So we avoid NSAIDs. We have given higher antibiotics to her, and we successfully treated. And the patient left home with baby in an ICU, but good prognosis. That's always a positive sign for us. So patient was discharged in a healthy manner. So we reviewed her after 10 days. We repeated her LFT, and that was absolutely almost the decreasing trend was absolutely more than 50%. And after 3 weeks, we have seen a significant change. The patient's bilirubins and SGOT, SGPT has become normal. So maybe I think we have to repeat even after 6 weeks. We planned for repeating the LFTs. So LFTs as well as her HB also to monitor any infective signs. Anything to be added, sir, for this case?
No, perfect, madam. I think that summarizes it nicely.
So coming to the case 2, sir. She is a second pregnant female. Second pregnancy, gravid 2, and she came with 31 weeks. She came at 31 weeks to us with previous C-section and history of hypothyroid, and she was referred here because she was diagnosed with IUD. There was no heartbeat. But liver, and the doctor has found with elevated liver function test and thrombocytopenia. And her first pregnancy was 2 years ago, but that C-section was done because of non-progress of labor. And present pregnancy, she conceived with ovulation induction, so artificial technique was used. And she had a regular ANCs in the private hospital, but she was very non-compliant. And second trimester, her quadruple screening marker showed increased high risk for the Downs. So here the fetus was abnormal, and that was very high risk. 1:15 is very high risk, but in spite of explaining, in spite of giving an option of amniocentesis, patient refused and they want to continue the pregnancy in spite of whatever it is. So patient was diagnosed with PIH at 28 weeks, and she was started on antihypertensives, labetalol twice a day, and her on admission and her general condition was absolutely fine. She was hemodynamically stable, but with BP is maintained only with tablets. Antihypertensive, she was on tablets. And as we know, immediately when fetal heart rate was not there, we do a reconfirmations with ultrasound. We found fetal hydrox was diagnosed, and IUD was there, and fetal weight is only 7-10 grams. So we investigated accordingly. When any patient comes with an IUD, so we usually check for the infections and the coagulopathy rearrangements, which are very important for us to treat, whether we have a time to deliver or whether we have a time to go for C-section or not. So immediately we have done the following investigations were done. And HB was 9.9 and WBC was 12,000. Platelets, there is a significant thrombocytopenia, 62,000. INR was normal. CRP was drastically raised. So we have to trace the infections and coagulopathy. So we have advised CRP. Total bilirubin is drastically increased to 3.8. Alkaline phosphatase is raised. That we won't take much into consideration. SGOT, SGPT they were also moderately raised. APTT was normal. Renal functions were good, and viral screening was negative. So after seeing this, what do you think, sir? Apart from the IUD, as an obstetrician, so I want to take out the baby as soon as possible so that I can see the drastic changes in the babies. But by seeing this, what do you feel how the liver got affected, sir?
Thank you, madam. That's a nice summary of the case. The important thing to understand here is, the first slide that Dr. Pujitha showed, common things are common. Now in sepsis, we see a lot of deranged liver function. Now the high CRP there is a testament to it, and another way to easily identify presence of sepsis, especially if it's bacterial, is to do a procalcitonin, and that will be very useful in these patients. In the context of severe sepsis, sepsis-induced hepatic dysfunction is very common. Now, if left untreated, this group of patients are the ones who are likely to progress to DIC. At this point in time, you only see a drop in platelets. That is overwhelming reaction to the sepsis rather than a HELP syndrome. I don't think it is HELP. But more importantly, this is related to the IUD and sepsis that is driving the entire hepatic dysfunction. Now, it's only a matter of time. If you don't deliver this patient on time, then you start to see the rising in INR and it will be more difficult. So this is a patient who you would want to intervene early. You don't want to wait another 3 days or 4 days to allow them to have spontaneous medical termination as you would otherwise. I know that is sometimes seen, but with the dropping platelets, rising LFTs, although the INR is at this stage normal, you may want to intervene early in this patient. That would be my way of advising, considering the risk to the mom and at this stage.
So this is sepsis-induced liver function rearrangements. So we are going towards sepsis, no sir, in this patient because CRPs was absolutely raised. So as sir told, we discussed and as usual, we planned for an emergency LSCS because as a doctor, I want everything to be finished when something is in your hands. So I don't want her to deteriorate more by leaving her like that or for trying for normal delivery. I think we are not having much time in our hands to protect her. So immediately we have taken a decision for emergency LSCS. As usual with blood products arrangements, like even not only FFPs, we arranged for PRBCs and even donor single donor platelets, or we can arrange this random donor platelets also. But we have to keep all this in hands and then go ahead for the C-section. We have successfully done C-section intraoperatively. Again, we have transfused 2 units of FFPs. We didn't transfuse any platelets. But by God's grace, that section went very well. This patient also never had any PPH or any wound site bleedings or anything. And after this, we managed her hypertension as usual as we managed the preeclampsia patients. So it was a very mild preeclampsia. So we managed with antihypertensives post-delivery. And sir, I think here also this bilirubins were really high. And anything else can be done to protect the liver for the further damage, sir, not to go for further damage?
I tend to use the hepatoprotectives, which is a combination of acetylcysteine, glutathione, and I have in some patients also used adenosylmethionine. Now, one of the things that I also use regularly is ursodeoxyfolic acid. It's very safe, well tolerated. Now, again, that is not something I would advise for all of you to go and use without speaking to a hepatologist locally to get their input on board because of the variability of presentations, what we've discussed in over the last hour. Now, especially a patient like this, now there is some apprehension that acetylcysteine may prolong APTT and VT in patients, but our experience in dealing with patients with acute liver failure secondary to paracetamol toxicity, where I see INRs up to 6, it's not the case. If anything, it helps. Now, there are some people who would argue against the use of anything else. Conservative management is probably enough. So it's only we are trying to improve the liver function there. We're not trying to change the eventual outcome. In that sense, yes, I would use those medications to help protect the liver. Nutrition is fundamental here. So some of these patients are malnourished. So in some patients, we've actually fed them with high calorie diet because they tend to be, the sepsis itself induces a degree of liver function, derangement in liver function. Hypoalbuminemia is a common thing that we see in these patients. On top of it, if you are septic, it delays wound healing. And especially some of these patients tend to be anemic, and that also impairs wound healing. So that's why, as you rightly did, keep the blood and FFP in stock, nutritionally support them, protect the liver with some hepatoprotectives where needed, and treat the sepsis aggressively. Now, if this group of patients, I would sometimes use antifungals, fluconazole, along with an antibacterial agent. And it's something that I picked up when I was working in the transplant unit, and that seems to work. Especially in pregnant women, candidal infection is very common. In the context of IUD, I tend to use this as an adjunct to medical therapy.
Perfect. So on the whole, we need to go for a higher antibiotics for this patient, and we can use broad spectrum antibiotics along with 1 gram, this Metrogyl, and 1 antifungals. So this is going to give us a very good results, along with replacement of albumins like either dietary forms or IV forms, depending upon the severity of the hyperproteinemias.
And just to
Shall we
add
move on?
one thing, yeah, sorry.
Sir.
Yeah.
Please, sir.
Source control is very important in this patient. Somebody who's as sick with such high CRPs, raised white cell count, low platelets, if IUD is the source of it, then it has to be dealt with immediately.
Yes.
Okay. Yeah.
So I think for this patient, for improving the platelets, I think we also started steroids. So steroids also, this was really helpful for her to improve the platelet counts and to maintain it and to prevent the secondary complications because of thrombocytopenia. So I think we have used it for 1 week, which was tapered accordingly, and we stopped it after two weeks. 2 weeks we have stopped it completely, and which gives us a very good result. And patient we discharge, this kind of patients we usually discharge once the CRP was controlled or the downfall trend was already seen and platelets above 1 lakh. We usually plan for the discharge. So for this patient also we have successfully treated, though there was a bad news with her with IUDs, but her mother condition was absolutely stable at the time of discharge. And here also we should not forget about that repeating all the tests after 6 weeks postpartum. That's it, sir. Shall we move to other cases?
Yeah.
So there was one more patient who was referred from the private hospital. She is a primary with 30 weeks, approximately 31 weeker, with diagnosed IUGR with preeclampsia, already had an abruptio because they have taken up for emergency C-sections because of fetal bradycardia, and emergency C-section, we came to know that that's a live child with the weight of 1.1 kgs and there was no intraoperative bleedings or bleeding PV. And shifted here in view of deranged liver functions, which was really very bad. And she came here for the further management. And when the investigations were done, and I should mention here the point, her BPs were absolutely high when she got admitted. It was around 170, 110. But good things were like, and along with imminent signs like blurring of vision and headache. Even postpartum, on the 0 post-op day, she used to have this complaint. And immediately we have started treatment for antihypertensive treatment was started and investigations were done. And investigations, HP was 7.3, platelets were 19,000, and PT was 11, INR was normal 1.33. Total bilirubins were drastically raised. It was almost 6. Direct bilirubin, it's 2. SGOT, SGPT were almost 2000 plus. And blood urea was drastically raised 110. Creatinine is 3.2. And APTT is 25. And the CUV proteins were 3 plus. While screening is negative. D-dimer is drastically raised. Fibrinogen is 124, which was lower side. LDH is also drastically raised. Electrolytes were lower side. So, sir, after seeing this immediately, what do you feel, sir?
I think this is any hepatologist or obstetrician's nightmare, but it's important to understand. Okay, so she's got all the full biochemical picture of what we would call as HELLP syndrome. So you've got low hemoglobin, there's LDH which is elevated, you've got hyperbilirubinemia direct, which is 2, indirect is high, your INR is rising, your SGOT, SGPT are in thousands, and you've got renal impairment, including AKI. And you can see that she's got pre-existing proteinuria, which is 3 plus of proteins.
Yes.
Yeah, so perhaps this fits classically into our definition of the hypertension-related pregnancy disorders. So she may well have had a degree of preeclampsia, or and now she's provided with a hepatic dysfunction. And biochemically, this fits in beautifully with HELLP syndrome. Now, the question is, how do we manage them? Now, the fundamental thing is we have to control the blood pressure. If you remember the Mississippi triad that we talked about, corticosteroids, magnesium sulfate, and very aggressive control of blood pressure. That is what is needed in these patients. They run the risk of hemorrhage, they run the risk of retinal detachments, they run the risk of liver infarcts, and so on and so forth. They get worse very rapidly, including acute liver failure. So this is a patient who you would want to keep in your ITU, nowhere else. This is a patient who you would want to be very aggressively supporting blood products, if necessary, if they are bleeding. This is a patient, even if you would want, if you have, I know your fibrinogen is within normal limits, you may want to even give cryo if it's low. and support them as best as possible to, and if necessary and they deteriorate despite all your supportive management, rehydrate them, keep them on all the best possible support, involve a nephrologist, and if necessary dialysis, and control the blood pressure. If despite that they deteriorate, these are the group of patients who are heading for transplant. But I would like to know how you manage this patient.
Yes, sir. So as an obstetrician, my first target is to see whether the antihypertensives were going on, because antihypertensives, for her, sir, we started NTG infusions. In spite of NTG infusion, which was not under control, we have started labetalol, and I have taken even physicians' support also to go for antihypertensives, because I've started almost labetalol 200 milligrams BD dose and with NTG infusions, which was not decreasing. So again, we have started beta blockers. Now with beta blockers, yes, we could see that BP was coming towards 140/90, which is because compared to 170/110, when she got admitted, it was around 170/110. Now it got controlled to 140/90. And again, immediately after, we started higher antibiotics to prevent infections. And blood transfusions, we have started to correct, as you told, we started blood transfusions. And 2 units of PRBCs were required for her. And along with that, because of this D-dimers raise and fibrinogens going lower side, and we had seen that coagulopathies, we have given 2 units of FFPs for her. And we have given 1 single donor of platelets also. After doing all these things, on 3rd post-op day, her, and not only antibiotics, and after that, we have even, after blood transfusions, we have started the magnesium sulfate prophylactic dose was also given as an obstetrician, because I don't want her to land up with any imminent, because of imminent signs, I don't want her to land up with postpartum eclampsia. I've given her only prophylactic magnesium sulfate. I didn't give her any continuations because she never throwed any eclampsias. Once, but any episode of eclampsia, we have to give a continuous therapy for almost 48 hours. And as usual, when we give magnesium sulfates, we monitor everything. Anyhow, for this patient, everything we monitored continuously, like vitals, saturations, urine output. And we have done a chest x-rays also to rule out any changes of pulmonary edemas for her. And second thing is, even the chest x-ray was also done. No changes were there. Pulmonary edema changes were not there. And obstetrics, this thing, after second post-op day, we keep on, after repeating the blood test and all, we can see the improvements on second post-op day, but there was no complete downfall. But her TLC was going upper side, and the thrombocytopenia, like from 19,000, we could reach around 80,000 with blood transfusions. But and along with this, third post-op day, we have second post-op day, we have sent for fundoscopy also. We could clearly see the fundoscopy changes, that hemorrhagic signs were clearly seen on that. And so that is also one of the reason I have given a prophylactic magnesium sulfate on second day. So this is the basic treatment we have done. We are keep on monitoring her, and we have seen changes, lot of changes in her hemodynamically, as well as hematological changes have been seen from third post-op day. So even in this, dialysis for this patient, dialysis was not required. Now her, maybe on third post-op day, I think her creatinine was around 2. There is a decreased trend in decreased fall in the trend. So we just monitored the patient till fourth post-op day very closely. After that, the patient got stabilized. Wound was absolutely normal. Dressing was also done. And the baby, as a baby is in ICU, we have taken care of breast also, not to get any firmness in the breast. Breast pumping is also required. So as an obstetrician, I feel almost which we can do, we have done, sir. But from renal, from the liver side, sir, what any other enzymes, the same enzymes will be added for this patients also, sir, or we usually keep it on hold for the spontaneous decrease?
As I said earlier, madam, we can use it in these patients for improvement in liver function. All we're doing here is supporting them. One of the things that we also need to look at is you can have such very high SGOT, SGPT, even if there's a small episode of hypotension. So ischemic hepatitis can also present like this. Although this lady had been delivered earlier and was shifted to as for post-operative care, it's also important to send the rest of the liver screen as well, because if it was just a placental abruption and she had an episode of hypotension, that can also explain and it would recover much more rapidly. But haptoprotectives do have some role in these situations, especially where you can't do anything else if this patient is deteriorating, and you might as well give some medication that will protect the liver and support them to the extent that whatever can be done to avoid a liver transplant. So source control, you've done what is needed. You make sure the patients are well rehydrated and make sure these patients don't have any episodes of further hypotension, that it doesn't get worse. Cover them with antibiotics if you're suspecting sepsis. Control their blood pressure, which you have done, and supportive management in terms of platelet transfusion and blood transfusion as necessary. And you've also kept a close eye on the wound, which is very good. And you've also checked your fibrinogen levels, which, if necessary, cryo may be needed in this group of patients. I think all in all, you've done a good job with this one. Glad that the patient is
with your support, sir. Yeah, patient is recovering. She's about to discharge, sir.
Yeah.
Sir, and one more thing, sir. When we see this kind of picture, so suddenly we know, as in obstetricians, we know there is an hypertension and typical symptoms of HELLP was there. And yes, this is the diagnosis for HELLP syndrome. But how do you differentiate with fatty liver, acute fatty liver in pregnancies and this HELLP syndromes? And how do you monitor them after 6 weeks? We always feel our job was done as an obstetrician. So after 6 weeks, what is a plan for this kind of patients, sir? Apart from this antihypertensive use?
Yeah, one of the questions that I get asked usually is, will I have it again? Especially in my second pregnancy or third pregnancy. Now, largely we can classify to some extent that there is a possibility of this happening again. So for example, if you have history of preeclampsia, you are likely to have it again. You may have any degree of patience. And so if you have HELLP, there is no evidence that it can happen again. So in the hypertensive disorders, the spectrum, in one pregnancy, you may have a full-blown case of HELLP, but that doesn't necessarily replicate again. But this is not the case with intrahepatic cholestasis. So there is some degree of familial risk that is attached to intrahepatic cholestasis of pregnancy. Again, acute fatty liver, if you look at the pathology of what happens, it's the homozygosity in the baby that is known to affect the overdose of fatty acids that are released into the maternal circulation, causing hepatic derangement. So that again does not necessarily mean that it can happen in the next pregnancy. So if there is a heterozygous baby, it may not be as severe. So to some extent, HELLP and fatty liver may not happen in subsequent pregnancies. So I don't tend to follow them up, but I always tell them that if things don't improve or you have deranged liver function, please come back and see me. For intrahepatic cholestasis, I do counsel them that in subsequent pregnancies, it is possible to have it. Now, in those patients who there is persistent hyperbilirubinemia at 6 weeks, I tend to do a full liver screen. I evaluate them for a full liver screen whether there is pre-existing liver disease in them, and that is mandatory. And it is in addition to the basic acute profile that I would send, where I would send HAV, HEV, and HSV, IgM on PCR respectively. So apart from that, in those patients where there is persistent hyperbilirubinemia, I would definitely evaluate them for chronic liver disease. Because as you rightly pointed at the beginning of your talk, some of them, it may just be a manifestation of a pre-existing condition. The body is going through the stress of pregnancy, what is physiological for most women. These patients can decompensate. And that is the important thing to understand.
Sir, what is the role of liver biopsy, sir? When we usually plan for liver biopsy, is it mandatory to get diagnosed or to know the pre-existing diseases?
Now, liver biopsy, we are moving gradually away from liver biopsy, and we have FibroScan. If you have somebody with FibroScan greater than 7.2 in a not obese person, it is fairly consistent that there is some degree of fibrosis, and any degree higher levels of fibrosis beyond F4, we can confidently diagnose cirrhosis. Presence of nodularity on ultrasound itself is diagnostic of presence of cirrhosis. Now, in acute fatty liver pregnancy, initially we used to use a lot of liver biopsies. With the advent of SANSI criteria, I think we've slowly moved away from doing a biopsy in acute stages. We can confidently make a diagnosis based on ultrasound, based on the clinical picture. I tend to use liver biopsies in those patients who I suspect autoimmune hepatitis, because that is the gold standard for me to before starting them on steroids. Because if we, in some patients, we give steroids for maturing the fetal lung, and that may in itself mask the or temporarily benefit the hepatitis type of picture in this group of patients. And when we follow them at 6 weeks, you see a persistent derangement in the liver function. In that group, I send off the immunoglobulins, I do an IgG levels, and I also send the autoimmune liver screen, and then I work them up for a liver biopsy. Now, there is some school of thought that you actually have to review them sooner than 6 weeks. So that's why I tend to see them after discharge at 1 week. If there's a downward trend, I then ask them to come back in 4 weeks. If the trend is not downward and if I'm suspicious, I tend to see them on a weekly basis, especially in this group where I suspect chronic liver disease or autoimmune hepatitis.
Sir, what is is there any standard information regarding the pregnancies post liver transplantation, sir? Because the patients will be on immunosuppressants. So all the immunosuppressants, whatever they are taking, can be taken in pregnancies, or is there any other modifications which can be done to before planning the pregnancy? Is there any other modifications has to be done, sir?
So almost all the cytotoxics that are used do not have a category or B in pregnancy. Now, generally, most of these patients are requiring a low dose of steroid and other cytotoxic. The one thing that is generally avoided is mycophenolate. We tend to reduce and stop the dose before somebody is planning pregnancy. I tend to give them vitamin supplementation with folic acid. I always counsel them that, look, it's better to conceive usually after the second year, because the first year there's a chance of rejection. If you suddenly drop down the dose of immunosuppressants, as the time passes on from the transplant, you need less and less immunosuppression to keep these patients from rejecting their liver. And liver rejection can be easily well controlled with low dose steroids. And in this group of patients, as you rightly asked earlier, we do sometimes do a biopsy to confirm it's acute host versus graft disease or rejection. And in those group of patients, we tend to be more aggressive with the immune suppression. Other than that, I think what is important is to counsel them that if they can plan the pregnancy, try and do it after the second year or close to the end of 18 months when your immunosuppressions are less, and try and avoid mycophenolate.
So there's one last case, sir. This was a very simple case, but I don't want to ignore even this levels of LFTs. So I just want a few clarifications from you. We got a patient, she is in primary gravida, came to me with 36 plus weeks, almost 37 weeks. And she was also referred from a private hospital with deranged liver functions, but it was not so heavy. So SGOTs, SGPTs were in the range of 150s and 200, 250. And at the time of admission, she was absolutely stable. There are no much symptoms like she had any pruritus or any diabetic history. No medical histories were there for her. And her the vitals were also absolutely normal. Immediately after seeing this, as an obstetrician, I reached the target. I mean, whatever the target I want, like 37 weeks was reached. And so we could not, I just don't want to wait. And we just rechecked the LFTs and all. And we found her LFT, her bilirubin was 1.5. And SGOTs, SGPTs were 150s and 250s. And remaining all PT, APTT, hemoglobin, platelets were absolutely normal. So as an obstetrician, 37 weeks, I'm always happy to deliver her. So we have taken up for LSEs and we have delivered immediately. The LFTs were improved. But what do you think for this kind of mild elevations can occur in which kind of disorders, and how to go ahead with this kind of patients?
See, almost all the conditions that we have discussed so far, we are aiming to reach 37 weeks as a target in our patient cohorts. So once you have achieved enough good fetal maturity, and a rising bilirubin pattern can cause fetal distress. Now, there are some patients who will have very mild elevation in their low 40s of SGOT, SGPT, and their indirect bilirubin tends to be higher than the direct. Unfortunately, they don't always have had a previous LFTs. And as soon as you repeat them within 24 hours, you may have noticed that the liver function is normal, but the bilirubin is just a touch up. And that group of patients may in fact be Gilbert's. So they may be a cohort where if you have done their LFTs at the time of starvation, at the time of increased body stress of infection, including pregnancy to that or strenuous exercise, you may have noticed a slightly increased bilirubin, but the rest of the LFTs tends to be normal. But if it is more than 100 or ALT is rising and bilirubin is rising, then you have to think about the other differentials we've talked about in the last or the last 1.5 hours. But in either case, if it's in the range of 150 to 200, and you've got a raised bilirubin of close to 2, and you have reached the target age in this particular patient where you want to be safe, you can, because the patient is otherwise asymptomatic, wait to see the pattern of the change for a period of 72 hours. And if you as an obstetrician feel that the risk to the fetus and the mum is high and the LFTs are getting worse, then you take them as a semi-elective, semi-emergency rather for section. If you have a window of opportunity where they're getting better, then you could probably wait longer if that's the choice from the mom and you as the obstetrician. But once you've reached 37 weeks, I think you've reached the fetal maturity that you would ideally want for any of the conditions that we've discussed so far. In that sense, I think it is safe to deliver. The choice will be dependent upon the progression of the patient. If it is Gilbert's, you can watch and wait. I have had some patients who have intermittent deranged liver function. I repeat them after a week, and they are normal. I just watch and wait. But in this particular group of patients where you have slightly elevated bilirubin, I would repeat them within 72 hours. And if it remains elevated, then go for either elective section or induction of labor.
So for this kind of patients, we have, almost, can we go for normal? Because for this patient, we have done C-sections for maternal request, sir. So this kind of, in case if it is Gilbert's or if it is like stress-induced maternal changes, liver function changes, those kind of people, we can definitely plan for normal delivery. So it's not like,
yeah, Gilbert's is physiological for a lot of patients.
Yeah. So we'll definitely, we can monitor every 6 hours. Maybe every CBP and PT-INR is more than enough to monitor every 6 hours. If it is drastically dearranging, any thrombocytopenic changes, increase in PNR, it's an alarming symptom, alarming test for us. So then we have to plan for C-section. Otherwise, for this kind of patients with borderline elevation and term, and if the patient got reached to term, definitely we can plan for normal delivery.
Yes.
That's it, no, sir?
Yes.
Thank you so much, sir. That was a wonderful discussion.
Thank you.
Kiran, sir, can we go ahead?
Ma'am, thank you so much. I was just looking at a very interesting discussion, ma'am. Thank you, sir, for coming for the webinar and shedding light on some of the aspects which are very, very practical as well as very clinical. Ma'am, there are 2-3 questions if you can take them. It's all right?
Yeah, please, sir.
Ma'am, I had one question actually, if you can start off with that. Ma'am, if somebody is having a pre-existing liver disease, so whether it's a cirrhosis or a hepatitis or a liver transplant or maybe a portal hypertension, when that person becomes pregnant, first thing I want to know is, does the disease flare up as it is? Second thing is, are there any chances of maternal fetal complications?
Okay, so that's a good question. In fact, it will take me a lot of time to answer. It's not a simple question.
Right, sir.
So let's concentrate on the topics that we've not covered here. So we've covered hepatitis and others. So chronic liver disease itself per se. So you can classify them into child's A, B, and C categories, depending on the presence or absence of ascites, encephalopathy, and other features of decompensation. So liver disease itself impairs your ability to conceive. So those patients who have chronic liver disease and you conceive, and if you have decompensation with portal hypertension, they are at highest risk of having bleeding at the time of delivery. And we see this, so we plan the pregnancy in this group of patients and electively choose to deliver them at a time when we can, after normalizing their esophageal varices with EVL banding either in second trimester. Now, the second thing to understand is, if you are putting them through a delivery, anesthesia itself is a risk factor for decompensation. So they may decompensate because of the additional stress that you're putting through them, especially in the form of a C-section. So it's not easy to manage them in either way. So decompensation can happen, but it's usually because of the stress at the time of delivery in the form of variceal hemorrhage, or when you're subjecting them through a surgery and the anesthetic effects of the surgery. So in that context, yes, if you have a chronic liver disease that is stable, who has managed to conceive, they may decompensate at the time. For other conditions, who are stable liver disease, who we've incidentally picked up that they have chronic Hep B but no decompensation, no cirrhosis in the liver, you can manage them as you would manage any other normal patient. So does that answer your question, Dr. Kiran, or you want to highlight any other specific?
Yes, sir. I was just curious, so I just asked the question.
Yes.
Thank you, sir. Ma'am, there's a question from Dr. Meenakshi. So there is a 34-week pregnant patient with a normal LFT, but the person has been having pruritus, and despite using Udiliv BD, there is no improvement. So what are the medications and the line of management, ma'am and sir?
Yeah. First, if it is any pregnant female, not only the liver function test, we need to always screen the diabetes also. So even in gestational diabetes, we usually see this kind of itchings. So first, investigations has to be properly done. LFTs along with fasting sugars and HbA1cs. In case if diabetes is there, if we cure the diabetes, definitely the itching is going to be vanished. Or in case if it is deranged LFTs were there, if Udiliv is not helping, sometimes antihistaminics will do better job. So, sir, anything to be added in this? Because I feel like
yeah, just to that's a very good way of approaching it, because this patient is not jaundiced. I think the LFTs are normal in this particular patient. We have to rule out other causes. The second thing I would also emphasize is the dosage of ursodeoxycholic acid in this group. If you are using it, try and use the higher side of the recommended dose, 10 to 15 milligrams per kg body weight. So 60 kg women, you are requiring 900 milligrams. So you can increase the dose of Udiliv if necessary. Udiliv just makes the bile more fluid. So in non-jaundice itching cases, it doesn't have a huge role, but people have used it to manage itching in this group of patients. And as Dr. Pujita mentioned, antihistamines do help, and we have used them in this group.
Thank you, sir. Ma'am, the next question is from Dr. Nazreen. I think this is probably for sir, I guess. Serum bile acids, is it a necessary diagnostic criterion for intrahepatic cholestasis? Cholestasis.
You tend to see a slightly higher cholic and lower chenodeoxycholic acid. That's one of the supporting evidences of coming to a diagnosis. But some labs may not be freely available everywhere, so it's not mandatory. It's not part of the diagnostic criteria, but I use it when I have, especially when you have rising ALT and AST and the patient is presenting with itching and there is mixed picture, then I tend to use bile acids, yes.
Thank you, sir. Ma'am, I think this next question is from Dr. Supreet Kaur. In your last case, ma'am, can you throw more light on magnesium sulfate prophylaxis?
Prophylaxis, yeah. For the last case, we have given that prophylaxis, sir. But see, according to the guidelines, magnesium sulfate guidelines, if you see, postpartum, in case severe preeclampsias, to prevent postpartum eclampsias with imminent signs like blurring of vision, headache, epigastric pain, severe vomitings, we need to give them prophylaxis. But in case if eclampsia was there, prophylaxis we can use anything, sir, like either Zuspan or Pichat's regimen. 2 regimens were there. In the Pichat's regimen, we have the flexibility. So I basically personally go ahead still for Pichat's only rather than Zuspans, which is recently being used. And RCOG guidelines proves that both are equally effective. So there will be a controlled monitoring. We have a controlled monitoring about this toxicities. Magnesium sulfate toxicities can be monitored. So magnesium sulfate loading dose of 4 grams and the 10 grams, 5 grams in each buttock we usually give for as a prophylaxis. Initial prophylaxis, but any eclampsia was thrown, yes, we need to continue for 24 hours. Then we need to give every 4 hours. The IM doses has to be given every 4 hours. So if we follow this for other 24 hours and having a look on all the toxicity signs like respiratory rate, knee jerk, urine output, there are few signs which gives us a guidance about toxicities. Then we have to think about the toxicity and then stop the magnesium sulfate at that point. So it's very important. We have to have a look on magnesium sulfate prophylaxis when any HELLP was diagnosed.
Okay, ma'am. Ma'am, probably one last question from my side. I think this would be for both of you. Generally, ma'am, if you look at the data on COVID, So there is a lot of conflicting reports. First they said elderly people above 60. Then we had cases in the US where people above 30 were more having a higher CFR. So pregnant women with liver disease, would you say that they are more prone to have a more severe COVID-19?
So,
Definitely, sir. Please,
yeah,
please.
go on, madam. Go on. Please.
Leme. I think you're the right person to answer this.
Sir was there. I couldn't resist asking the question.
Yes. Rather than obstetrician answering.
Right. So again, good question, Kiran. Anyone with any degree of immune suppression are at higher risk of acquiring a more severe form of COVID. So you divide yourself into age groups. The highest mortality is seen over the age of 65. In the 6th decade of life, the severity of the infection is high. So anyone with immune suppression, anyone with pre-existing cardiac disease, diabetes, liver disease, if you look at how we have advised them since the days of quarantine and the lockdown, for most of the people with normal immune systems and younger age group patients, we've said you just have to stay safe. For liver disease patients who are post-transplant, who have decompensated liver disease, who have otherwise compromised immune systems, we even went to the extent of advising isolation strictly so that they're not coming in touch with anyone with acute respiratory tract infections. So their ability to pick up an infection is high, and their ability to have a more severe form of disease is high. So any stress in a decompensated liver patient that the body goes through, either in the form of an infection, infarction, any other forms of stress, can cause them to decompensate. So if you look at the way the general guidance has been, it is slightly different for these high-risk patients that isolation has also been advised from certain groups. So they tend to be a higher risk. And that is how I'd approach this group of patients. Yes, they are higher risk. Yes, they tend to have a more severe form of disease. They tend to be having higher mortality in this group of patients. And if you look at some of the causes for liver disease, they tend to be diabetics with NASH progressing to cirrhosis. So they are already having multiple comorbidities that puts them at higher risk. Most diabetic patients and hypertensive patients also have cardiac disease in addition to liver disease. So you are looking at multiple comorbidities in this group of patients. So yes, it does make them highly prone to these infections and a more severe form of disease. Does that answer your question, Kiran?
Yes, sir, definitely. So I was recently diagnosed to be a diabetic about 1 year back.
You don't have to announce it on the webinar, but I'm sure you're taking good care of yourself.
Yeah, sir, definitely. So I would like to give the first thanks to the audience for being very, very patient for a very, very fantastic discussion. I think what made it very interactive was Sir sparing his time from his busy practice to come and address us. Thank you so much, sir. We were very privileged and happy to have you here. And thank you so much, ma'am. I always keep thanking ma'am, but I'll thank ma'am again. So ma'am always brings up very, very interesting topics. Like last time we had IUGR. I think we had a lot of very good feedback from the audience as well. So thank you, ma'am, for arranging this program, and also thank you, sir, on behalf of Shield Healthcare to join us. Thank you.
Pleasure is mine. Thank you very much. Cheers.
Thank you so much, Sudhir, sir.
Yeah.
Thank you, Kiran, sir. Thanks for the opportunity.
Thank you so much, ma'am.
Thank you.
The organizers. Thank you.
Yeah.
Stay safe, all of you.
Yeah, stay safe.